Hello from Team Simatree. Recent rises in maternal mortality in the state of Virginia represent a significant opportunity to leverage data to improve outcomes in the state. We performed a qualitative and quantitative review of information we could find regarding maternal mortality. On the qualitative side, we reviewed recent reports and publications to understand the factors and trends that contribute to maternal mortality. Through a quantitative review of data on MMRIA critical factors, we uncovered a common theme of needing to seek care and failure to get to needed care in time. As we looked through available reports, we thought about how we could align a potential solution that addresses the theme of needing to get care in time to two of the six key focus areas from the 2021 Health and Human Resources Plan. These two focus areas were healthcare environment and community-based services.
So we went out and got a lot of aggregated demographic data by zip code and plotted it on sort of a map of Virginia. And some of the factors we noticed that we think are the most important are median income as well as race. And as you can see from the map, so we have the median income, you can see the darker purple and blue areas are where income is the lowest, and the greener and yellow areas are where it's the highest. And as you can see, a lot of the maternal deaths happen in areas with lower income or lower income compared to the general region. We also noticed that they weren't just happening in either rural or urban areas. As you can see, sort of there's clusters in Northern Virginia, Richmond, and the Norfolk area, as well as a bunch of maternal deaths scattered throughout the more rural western part of Virginia. We wanted to look at other factors that could potentially be involved. So some of them are knowledge barriers or transportation barriers, but as we went further along, we decided to build a risk model that really looked at individual data.
As Kevin said, we have to get past the aggregate data to the individual level of data. As you can see here, that will allow us to build a person-centric risk assessment model that will allow us to assign a risk score to each individual. We recommend using the score from prenatal all the way through postpartum. From that, we can apply that risk score of high, medium, low to each individual and then get them the right services based on their level of risk. In order to build that risk score, we need to bring in the data that supports the risk factors that we've identified that can identify those women at high risk. We would also want to include information that was not available to us for this study, such as access to public transportation and appointment information history, which would allow us to be able to build a more robust model, including those individuals who had missed their past appointments as a predictor for whether or not that could lead to some sort of maternal mortality. Once we have that data combined, we can build an effective risk assessment model, as Steve will show you in a moment.
We built a sample risk model for the entire population of available MMRIA deaths, but we're only highlighting those available in the Norfolk-Suffolk area in this case study. We began by quantifying key data points from the MMRIA data, such as known mental health diagnoses, which were prevalent in many of the cases, or prior hospitalizations or substance abuse history. We also gathered data from publicly available sources on the nearest health facilities, such as hospitals or substance abuse treatment facilities or mental health facilities, and even OBGYNs to create a distance calculation to those individual addresses. The combination of these variables were treated as risk factors within our model. While we created our own weighted methodology, it can be adjusted in coordination with SMEs. We believe that the best risk model is a combination of data revealed and heuristics from the SMEs. While we weighted the distance of certain health facilities the heaviest in our example to demonstrate the potential impact and influence that being farther away from facilities might make you a higher risk individual because it makes you harder to get the care that you needed. Our final model would be able to prioritize and bucket these individuals into those programs to identify the most appropriate approach to get these individuals the care and assistance that's needed. Now, to supplement our risk model, we are also proposing the creation of a mobile application that takes an individual's location and helps them identify the nearest location of key services, whether it be hospitals or substance abuse treatment facilities or mental wellness centers. Now, the idea is to provide as much information individuals' fingertips to streamline the process to getting the required support. Now, the risk score may not necessarily be shown to the individual, but we believe it can be integrated as part of the application. So higher risk individuals could and should receive more push notifications to make an appointment. They should get more information around key risk factors or early warning signs that might be associated with their particular case. We also like the idea of the creation of mobile health units, clinics, using the geolocation of individuals from the phone app to send the mobile unit to. This concept has been successfully utilized in rural areas, but we are proposing the expansion of these mobile clinics to urban areas as well, to go again, to get the individuals the services that they need. In summary, we feel that by creating a risk assessment and creating a mobile app that's able to push notifications to those individuals in need, Commonwealth of Virginia can begin to close the gap to maternal mortality, because even one death is too many.